Hello and welcome to Fits on the Go. My name is Saras and I'm a cardiology fellow at the Mayo Clinic in Rochester. With me today is Dr. Koen Ameloot, who was the first author on the NeuroProtect Trial that was presented as a late breaker here at the AHA meeting. Dr. Ameloot, welcome to Fits on the Go.
Thanks.
So Dr. Ameloot, the NeuroProtect was a very interesting trial. Could you tell us a little bit about it for the Fits?
Of course. So, as you probably know, post-cardiac arrest patients, they have a poor prognosis. Even after restoration of spontaneous circulation, survival and good neurological outcome is around 40%. 80% of these patients dies due to post-anoxic encephalopathy. And this is best explained by a two-hit model, the first hit being the no-flow and low-flow period before achieving RUSC. But the second hit is hypoperfusion or reperfusion injury during ICU stay. Current guidelines actually recommend, besides targeted temperature management at 33 or 36 degrees, to target a mean arterial pressure of 65 millimeters of mercury in these patients. However, we showed that in an observational study that patients treated according to the guidelines with a mean arterial pressure of 65 millimeters of mercury, they experience a profound drop of the cerebral oxygenation and perfusion during the first 12 hours of ICU stay that may be responsible for the second hit by causing hypoperfusion of the brain. So the first question that previously was, what is the optimal blood pressure in post-cardiac arrest patients? So the optimal blood pressure in post-cardiac arrest patients should maintain cerebral perfusion without exposing the damaged ventricle to excessive afterload. And in an observational study, we showed that maximal cerebral oxygenation is maintained with a blood pressure of 100 millimeters of mercury. So the aim of the NeuroProtect trial was to investigate whether early goal-directed hemodynamic optimization, which means targeting a mean arterial pressure between 85 and 100 millimeters of mercury and a mixed venous oxygen saturation between 65 and 75%, by additional fluids, inotropes and vasopressive agents during the first 36 hours of ICU stay, is safe, is able to improve cerebral oxygenation and perfusion, able to reduce anoxic brain damage on diffusion-weighted MRI, and able to improve functional outcome at 180 days.
That's definitely a very interesting and sound scientific rationale for this study. So enlighten our viewers on what your study found.
So first of all, we found that it's completely safe to apply early goal-directed hemodynamic optimization in these patients, despite the higher use of inotropes and vasopressive agents in patients assigned to receive the intervention. Adverse event rates were actually lower, with a 60% relative risk reduction in the rates of recurrent cardiac arrest. This is actually quite new because generally speaking, ICU physicians think that you should try to minimize the use of inotropes and vasopressive agents in ACS patients in order to minimize the risk for arrhythmias. But in our case, it was actually the other way around, and future post-hoc analysis will explore the hypothesis that improving coronary perfusion by improving blood pressure may result in a faster relief of the arrhythmogenic substrate. So first of all, it was completely safe to do it. Second of all, it improved cerebral oxygenation and perfusion during the first critical 12 hours of ICU stay, thereby for the first time providing the proof of concept for these new hemodynamic targets. However, this did not result in a reduction of the anoxic brain damage on diffusion-weighted MRI, and also did not improve functional outcome at 180 days, although there were some favorable trends, but they were not significant. But of course, the trial was not powered for it.
Congratulations, that is definitely hypothesis generating practice influencing study. Now, a couple of additional questions that I had on the study for you. Obviously, there is this ongoing debate in cardiac arrest without a STEMI about the timing of coronary angiography and plus minus PCI in these patients. And also there's some discussion about use of mechanical circulatory support in patients with concomitant cardiogenic shock. Could you comment on these aspects in this study?
First of all, on the timing of coronary angiography, there will be a few randomized controlled trials coming out next year. One is in the Netherlands, and they studied actually non-STEMI patients with VF, hemodynamically stable. So these are really the patients that we are in doubt whether it's worth the effort to go for early CAT or not. So the randomized controlled trials will show. The second question is about mechanical cardiac support in these patients. I'm really a believer of mechanical cardiac support because I think if you are hypotensive, then you hypoperfuse your brain. So if you cannot do the job with inotropes and vasopressive agents, I think you should have a low threshold to go for mechanical cardiac support. In my case, I prefer Impella above VA ECMO, because with VA ECMO, of course, you have the mixing of deoxygenated and oxygenated blood with a clear risk of hypooxygenation of your brain. So that's why I prefer Impella in these cases. Of course, there are no randomized data on it, but just based on the physiology.
Thank you. Those are really excellent points. One other question now, with neurological outcomes being such a priority in cardiac arrest, what do you think are future avenues, both from your group and others in the world, about next avenues for research in this topic?
So the major goal of future research, I guess, is to find a good surrogate endpoint for these kind of trials. In my case, we tried diffusion-weighted MRI, hypothesizing that the larger the extent of anoxic brain damage on diffusion-weighted MRI, the poorer the outcome. However, the area under the curve was only 0.6, so it's very disappointing, and I also think that diffusion-weighted MRI has no place for neuroprognostication in routine daily clinical practice. Other trials used NSE as a surrogate endpoint, but of course it has a very poor sensitivity, so it's also not a good surrogate. Recently there came out a very interesting study on neurofilament, and actually it had a very good area under the curve, and I think this is probably the way to go. But future trials will need to reconfirm these findings.
Dr. Ameloot, thank you so much for sharing your knowledge with us today on Fits on the Go. For more videos like this, please log on to youtube.com/Fits on the Go. Thank you.
Thanks a lot.